This module is a continuation of the overview of interfacility transport medications outlined by the Colorado Department of Public Health and Environment Interfacility Transport Regulations. We will be covering the remainder of the cardiovascular formulary of this waiver. A 5-medication expansion of the Colorado EMT cardioactive drug list are mentioned here. Note that dobutamine, a sympathomimetic usually used in the instance of heart failure and/or cardiogenic shock, is listed within this waiver, but is to be attended by a critical care paramedic or nurse only, unless you hold a specific waiver from your medical director. For this reason, we will not cover its pharmacokinetics today. With the exception of amiodarone and lidocaine that can be attended by both an EMT intermediate and a paramedic, patients receiving these drugs during their transfer should only be followed by paramedics. Remember that the drug regimen must have been begun in hospital and are not to be initiated in the field. The attending healthcare professional should continue the standard of care outlined by the facility, and any alterations requires a direct verbal order from the medical director. Again, you, as the medical provider, reserve the right to decline transport of a patient if you feel that their care requires a level beyond your capability or comfort level. We will begin with a refresher of the normal physiology and pathophysiology of the heart before we discuss the pharmacology, medical indications, and side effects of these 5 drugs. Cardiac anatomy, cardiac action potentials, and EKG tracing or correlation is important to have in the back of your mind when grasping the mechanisms of these drugs. Their targets and the basis for their classification lie within the ion channels that underlie each action potential. Naturally, drugs that affect certain ion channels will also alter their EKG. If it has been a while, re-familiarize yourself with the anatomy of the electrical system depicted in red at the left of the diagram. In healthy individuals, electrical signals begin in the sinoatrial node that is nestled within the right atrium. Those signals travel rapidly through the atrial muscle via small holes at cell junctions known as gap junctions, depolarizing the tissue before coming to a brief halt in the atrioventricular node. The signal pauses here for the contraction and therefore movement of blood from the atria into the ventricles before the electricity moves forward into the bundle of His, bundle branches, and finally the Purkinje fibers to depolarize the ventricles. As you may recall, there are 2 different cells of electricity in the heart, fast response cells and slow response cells. This is somewhat a busy diagram, but focus on the 2 boxed graphs and how they correlate over time with the familiar EKG tracing at the bottom. I have highlighted the graph of nodal cells, or slow response cells, in green, whose cell functions are responsible for the P wave and the PR interval of the EKG. The fast response cells are most responsible for the QRS complexes and QT interval of the EKG. We will go into these action potentials a little bit more in detail and revisit later how EKG tracings might differ if these cells are altered by medication. The main difference between the 2 cardiac cells are the ions that are responsible for the flow of electrical current. Here is a side-by-side comparison of the dreaded graphs of the 2 cardiac cellular action potentials. To orient you, the y-axis represents the voltage held by the cell membrane, expressed in millivolts. At rest, both of these cells hold a negative membrane charge, meaning that there is a relative lack of cations within the cell's cytoplasm. As their membrane charge becomes more positive, or as it approaches 0, it also approaches a threshold value, which is the cell's sweet spot for an action potential to occur. The x-axis represents time. Although there is a successive phases of each action potentials, we skip phase 1 and 2 of the nodal cell or the slow response cell here shown on the right. Slow response cells, also referred to as nodal cells, are found within the SA and AV node and exhibit the physiologic phenomena of automaticity. Special ion channels, called funny channels, give these cells the ability to alter membrane resting potential towards their excitation threshold without external stimuli. The cellular collection that make up the sinoatrial node have the highest intrinsic automaticity and therefore serve as the pacemaker of the heart. They spontaneously depolarize at a rate between 60 and 100 times per minute. Remember that specialized atrial muscle fibers, AV nodal cells, and His Purkinje cells also display this automaticity phenomena and can become the site of an ectopic pacemaker if or when the cardiac physiology becomes compromised. Begin with me at the bottom left of the graph, phase 4. At rest, these cells exhibit an approximated membrane charge of negative 60 millivolts. This gradually creeps towards a positive number as positively charged sodium ions slowly leak into the cell. Once threshold has been reached, a slow upstroke, hence the slow response name, begins, carried out by the influx of calcium ions within the cytoplasm. This occurs until a specific set electrical charge is met. Notice the peak in the graph, when calcium channels are no longer stimulated and begin to close. Simultaneously, at this voltage-sensitive potassium channels are stimulated to be open. Positively charged potassium begins to leave the cell to begin phase 3, the repolarization phase. Potassium ions will continue to leak out until a certain negative voltage is reached, and then the channels close, and the cell has reached phase 4 once again. Myocyte cells are the muscle cells of the heart that are stimulated by electrical activity carried out by the nodal cells. These cells are also known as fast response cells because of the very steep slope of their depolarization phase, shown here as phase 0, on the left portion of the graph. The resting membrane potential of myocytes is around negative 90 millivolts and does not vary like nodal cells do. Note that this phase is straight, steady line. Once a resting cell membrane is stimulated by an external source, voltage-sensitive sodium channels open and positively charged sodium ions rush into the negatively charged cell. This happens very quickly, which allows for the very steep slope of phase 0. This inward sodium movement occurs until a certain internal charge is reached. Sodium channels then close and 2 other channels open. Potassium channels open first, allowing a brief period of potassium exit that you see in phase 1 before calcium channels open. Slow inward movement of calcium balances out the movement of potassium outwards, leading to this plateau phase of depolarization seen in phase 2. This plateau phase is imperative to delay the signal long enough that the muscle can contract and relax fully before it can be re-stimulated. Have you ever heard of getting a muscle cramp in your heart? No? Well, this is why. Note that the slope of this curve gets steeper during phase 3, when calcium channels are activated, allowing only potassium movement out of the cell. This repolarizes the membrane potential back to rest, and phase 4 may begin again. So why is this boring ion stuff relevant? Each of these channels are subject to the manipulation by drugs. It is important to keep in mind these steps when we learn about the mechanism of action of the cardioactive pharmacology within this waiver. Take a moment to review these steps here. You now know that sodium is a very important player in both fast and slow response cell physiology. This picture illustrates the sodium channel that is involved in muscle physiology. Recall that it is important that cardiac muscle cell completes its action potential and is not stimulated before the heart is able to contract and relax. To ensure that this happens, sodium channels cycle through different conformational phases during the cardiac action potential. Transitions between each state are dependent on membrane potential and time. Two gates exist that control sodium movement through the channel. The letter M indicates the activation gate, and H indicates the inactivation gate. On your far left, at rest, note that the inactivation gate is open and the activation gate is closed. Sodium is not able to flow from outside the cell to inside the cell. At the bottom of the picture, you'll see that during phase 4 of fast response cells, sodium channels are, quote, at rest, quote, with this gate set up and ready to be stimulated. Once threshold is reached, activation gates open and sodium rapidly enters the cell. The middle photo depicts the gate setup and reminds you of phase 0, depolarization. Once depolarization is complete and the cell has reached an electrical charge sufficient enough to open potassium channels of phase 2, both activation and inactivation gates close. Having both acts as a fail-safe to ensure that even if there is enough electrical stimulus to open the M gate again, the H gate will remain closed, sodium will not move, and the cardiac muscle may complete a full contraction and relaxation cycle without being stimulated prematurely. The dashed line at the bottom of the right corner indicates the part of the action potential when most sodium channels are inactivated and unavailable for reactivation. The magnitude of phase 0 of fast response cells is the primary determinant of the conduction velocity, or how rapidly a signal occurs. The greater the rate of phase 0, depolarization, is equal to greater conduction velocity. This is related to the number of sodium channels that are in the resting state and are able to open all at once. More sodium equals faster depolarization. Conduction velocity is also slowed by subthreshold repolarization towards resting membrane potential. Remember that at rest, fast response cell membranes are charged around -90 millivolts. And in order for sodium channels to be configured in a way where they can be stimulated, an ambient charge must be met that is close to that of the cell's resting potential. If these cells only reach, say, -75 millivolts or -55 millivolts at rest, there will be less sodium channels in their resting state and therefore less sodium channels to contribute to the rate of phase 0. Damage to the cardiac muscle, such as ischemia, cellular injury, or excessive stretch, can cause a more positive resting membrane potential, and therefore impaired conduction. This also gives way to the potential for arrhythmias. Note the red arrows in graph B, highlighting a more positive resting membrane potential and a more gradual slope of phase 0 that takes a longer period of time to reach the peak. Graph B also introduces the idea about the length of time the action potential takes. Highlighted in blue, notice the amount of time it takes for the cell to repolarize, called the effective refractory period, and stands for the amount of time it takes for a cell to become ready for another stimulation, and therefore another action potential. Imagine what this could mean for a heart that demands a certain pulse rate but cannot achieve it. We are getting closer to the relevance of all this science, I promise. There exists only 4 distinct classes of antiarrhythmic drugs, named creatively as Class 1, Class 2, etc., which are classified based on their predominant mechanism of action. Note the use of predominant, meaning that some medicines have multiple mechanisms of action but still only fall into one main class of drug. Some drugs stand alone, unclassified. As a general rule, classes 2 and 4 are rate-controlling drugs, and classes 1 and 3 are rhythm-controlling drugs. The main rules for each are discussed now. Class 1, all members of this class block sodium channels and affect phase 0 of fast response cells and phase 4 of slow response cells. By so doing, they slow or block conduction and slow or abolish ectopic pacemakers. Subclasses of class 1 drugs depend on their simultaneous effects on potassium channels and their effect on the action potential duration. We discuss lidocaine in this picture as a representative of this class. We will start with lidocaine, or xylocaine, if the brand name is mentioned to you. It falls within class 1, subtype B, whose agents rapidly associate and then dissociate from sodium channels, especially those that are in either an activated or inactivated state, making this class very useful in tachyarrhythmia treatment, where the cells are firing often and allows for less of an effect on cells that are depolarizing at a normal rate. Lidocaine's effect on the action potential is mainly to shorten phase 3 of repolarization, which shortens the action potential duration overall. This primarily makes it very effective in treating ventricular re-entry and causes of ventricular arrhythmias that can be seen with cardiac ischemia. But since lidocaine does not affect the rate of conduction, it is not effective for arrhythmias originating in the atria or the AV junction. In the IFT world, you may see continuous infusion of lidocaine IV in a patient who has been found prone to ventricular arrhythmias post-myocardial infarction, or for the prevention of recurrent ventricular tachycardia or ventricular fibrillation in a ROS-C patient, perhaps. Adverse effects include cardiac arrhythmias like a heart block and bradycardia, but mostly are central nervous system in nature. Other than slight prolongation of the QT interval, EKG changes are minimal. Class 2 antiarrhythmics are beta-adrenergic antagonists, which work to slow phase 4 depolarization of slow response cells. This will overall depress automaticity, prolong atrioventricular nodal conduction, and decrease heart rate and contractility. We do not discuss a specific drug from this class today, but you'll recognize them in practice as the beta blockers. Class 3 antiarrhythmics block potassium channels and thus diminish their outward movement during repolarization. This prolongs the duration of action potentials without altering phase 0 depolarization or the resting membrane potential. We discuss amiodarone together, but please note that all of the medications within this class have the ability to induce arrhythmias. Amiodarone's brand name is Cardarone and is a classic cardiac medication in EMS. It has a very complex mechanism of action, as it holds properties from all 4 classes, but mainly from class 3. For the purpose of this lecture, continuous IV infusion indications of amiodarone are in the treatment and prophylaxis of severe refractory SVT, ventricular arrhythmias, and for sinus rhythm maintenance in patients that have had symptomatic atrial fibrillation. Amiodarone has a very long half-life, upwards towards 8 weeks, depending on the source that you read, and it takes weeks to work clinically if not being used in an emergency bolus situation. The mechanism of action of this drug includes the possibility of QT prolongations as well, and continuous cardiac monitoring should be a priority. Class 4 drugs block calcium channels. They decrease the inward current carried by calcium, resulting in a decreased rate of phase 4 of slow response cells. This effect will be greater in tissue that fires frequently, which means greater effects in the SA and AV nodes, as well as in smooth muscle of vessels that depend very strongly on calcium influx to constrict. Due to this mechanism of action, these drugs are also negative inotropic agents in that they decrease the force of contraction. Of the calcium channel blockers, there are medicines that affect the heart more so than the vasculature and vice versa. Diltiazem lands right in the middle, affecting the vascular smooth muscle and cardiac muscle equally. This aspect of its actions will decrease peripheral vascular resistance and cause relaxation of smooth muscle of blood vessels, decreasing both systolic and diastolic blood pressure. You may encounter a patient receiving diltiazem for the treatment of chronic, stable angina that may be heading for ablation. A patient who has recently had a non-STEMI secondary to hypertension, or a patient that is suffering from an atrial arrhythmia being controlled pharmaceutically. Be on the lookout mostly for bradycardia and hypotension. Again, this drug is a negative inotrope and can also exacerbate heart failure. Nicardipine is also a calcium channel blocker that affects calcium channels mainly in arterial smooth muscle. Therefore, it mainly acts as a vasodilator and has minimal effect on cardiac conduction or heart rate. These properties make nicardipine very effective in the treatment of angina and hypertension. Due to the fact it has very little cardiac action and sympathetic antagonism properties, you can see rebound tachycardia with this drug and, as with diltiazem, hypotension. Nitrates decrease coronary vasoconstriction or spasm and increase perfusion of the myocardium by relaxing coronary arteries. Their potent venodilator activities also decreases myocardial oxygen demand by reducing venous return to the heart. Nitroglycerin is converted to nitric oxide at or near the plasma membrane of vascular smooth muscle cells, which will then activate enzymes inside the cell that increase the conversion of intracellular substances that eventually lead to the relaxation of smooth muscle cells and therefore dilation of the vessels. You will see patients on IV nitroglycerin for the treatment of angina that is not responsive to sublingual or PO nitroglycerin. Perioperative treatment of hypertension, myocardial infarction complications, congestive heart failure, and pulmonary edema all call for the IV form of this medicine as well. Be aware that special non-absorptive tubing must be used when delivering this medication IV. The most common adverse effect is headache and hypotension, but also includes facial flushing and tachycardia. In summary, all drug groups we've discussed affect the heart in different ways. When considering complications or acute changes in patient status while they're being treated with a medication within this formulary, it is important to go back to the basics. I hope that this has been helpful to review the physiology and pharmacology of the drugs included in the IFT transport waiver.